Hi you guys, welcome back. This one's going to be a little bit more fun. I'd introduce you, but then if you have to be introduced to the person sitting next to me, you're probably watching the wrong tape. So, today's presentation is on Qapi, and as you know, Alicia is new in that role. So I thought, as I went through your interview guide and what was appropriate for all of you to know, that I could actually be showing Alicia that, or the examples, and giving her a chance to clarify some of the points that she may still be a little fuzzy on. Alicia has to date not gotten a complete evaluation. That she's gotten. Now go back and watch the one before this that was about evaluations. She has not gotten a complete orientation, so I thought maybe it'd be nice to see a face beside mine on here. And Jody's was only 4 minutes and 41 seconds long, so maybe we'll put Alicia's face on longer than that. So get your interview guide out. Thank you for helping out, Alicia.
Of course.
And what is in the guide for Qapi that you guys have is on page 9. Remember, you have page 8 and 9. So on page 9, near the bottom, it's actually in the Director of Healthcare Services section. It's not in the Patient and Family section, but it's relevant, and they're going to ask you in another section that same question. The format for, it's the next to the last one, the format for maintenance of patient-family records is reviewed and updated as necessary. And that does involve all of us, because that regulation means that the med records and what's in them in the order, that it has a written, that we have a written policy or a written guideline at least, that all of these things should be in this section, all of these things should be in this section. So, and when we sit down with the surveyor, one of the things that we're going to do, and you'll do this the next time we're surveyed, you won't have to do it by yourself this time, but the next time we're surveyed, you'll do this, then you'll open that record and you'll say, well, over here are all the admission paperwork, face sheet, and all of those forms that are signed when we start the patient that are in the red notebook, our starter care packet. Then this next section is all of Dr. Adams' section, that it has the doctor's orders, the certs, the recertifications that he signs, etc. When we open it to this section, this is all the changing stuff. So it has like the hospice aid assignment sheets, and the CPOCs we do every 2 weeks, because it's all changing. And this is okay. So this regulation is expecting all of the staff to understand and know that we have written guidelines for what the medical record file itself should look like and where the stuff should be found, and that's being well organized. Okay, and we're supposed to periodically review that the format works for us. Those periodic reviews are some of the things that I do with Wendy, and or even the office personnel in this one, like, how is it working when the chart's that fat? If we thin it out, does it still work? Would it be better if we had 3 ring binders? No, because it's open and close, and all, you know, and these things get out of whack. So, okay. Then for the staff, if you'll go to your next sections, which were pages started on 18, but the Qapi comment is on page 19. Staff describes an understanding of the complaint process. So I don't want to put you on the spot, Claudia. Sorry. See, I should do introductions because I don't know who I'm sitting with. Hi, Alicia.
Hello.
I should ask you, because you are already actively involved in complaints. Not that we get very many of them, but why don't you share for us what our complaint policy looks like? What comes to mind when you read the regulation that says staff describes an understanding of the complaint process?
What comes to my mind is that they are able to explain to the family members, if they do have a complaint, who they can contact that for. So obviously first we want to contact in office, so either going to Jody or having the family call Jody directly, or myself if Jody isn't there, and then we can follow up with the family, get their understanding or what's kind of gone on, and that has to happen within the 72 hours, and following up with any kind of complaint. After that, then we have to decide on our plan of action and take those steps, but every complaint should be resolved within 2 weeks.
Excellent. That's great. Absolutely. And not only is every piece of that right, but we far exceed what our actual written policy is. We never wait 3 days to follow up on a complaint. And a complaint is defined as anything that the patient or their family would like to have happen differently, anything at all. And so if they talk to the case manager and have a complaint, as soon as we know about it, we're on it, whether it's with the equipment company, etc. There are forms that you'll fill out, and when one of the staff comes to you as the Qapi person, it's best for you to fill the form out, because we don't get enough complaints that the rest of the staff would need to know. You guys don't need to know how to fill the form out. You just need to share the complaint immediately. And then, Alicia, you've filled this out before, so you'll fill the form out and, and ask the description and the investigation, etc. And now that we have a director, you'll have it hand it on to Jody, and she'll do her investigation or whatever. Eventually it makes its way to me. And I also keep a log, an actual log for the year, and anytime there's a complaint, I log it on, and then the one-page log will have however many we got for the year. So nicely described. Okay, well done. So staff, what else can you, any of you out there tell me about complaints? When do we talk about them? I bet you know.
Every IDG.
I knew you knew. You knew too, didn't you? You guys said it. Yeah. Okay. So, the next QA-related staff reg is on page 22 of your interview guide, and it is Hospice 2, 4C, 3C, which is the third one from the bottom. IDG members describe the process for integrating the data elements into the performance appraisal program and describe one example of the utilization of the aggregated data for improving a problem. What? All right. This is the big one, and this is really why we're sitting here today, because that description right there, what they want you to do is tell me what the Qapi program is. You're an IDG member, so what is Qapi? So that's really why I wanted to do this presentation for you, because Qapi, which stands for what?
Quality Assessment Improvement Performance. Performance Improvement.
That a girl.
Yeah.
That's good. That's great. And you know what? And that's a perfect example, by the way, of what happens when you're under the microscope. That's why I want to do this for you guys, because even when you know it, backwards, forwards, do it right every day, when a surveyor looks at you and asks you the question,
You get nervous.
yeah, so that's beautiful, but you know the answer's in there.
Yeah.
And so she'll let the answer come to you.
Mm-hmm.
She knows you've got it. So quality assessment, performance improvement. In general, what that is it's a set of guidelines, which the conditions of participation, and they're here in our Qapi manual. You guys know the conditions of participation are the federal regulations that govern what we have to do.
I think it's important to also say that the Qapi manual is in my office, along with all of the other manuals that are on that wall too, in case you guys need it.
Perfect. Great. So we have the conditions of participation, which tell us what we have to do. Then we have our own set of policies and procedures, which all of you have in your 3 ring binders, you have that chapter is the one chapter out of the great big P&P manual that you have every single page of. Chapter 8, the Qapi chapter, because every one of you is on the Qapi committee. Every one of you is a part of what we're doing. We're assessing the quality of our care for the purpose of improving our performance, okay? So you have all of Chapter 8 in your policy and procedure manual. There are our own policies that mimic what the conditions of participation tell us we have to do. One of which thing is to have a written plan. And every year we review to see if our plan still covers everything we're supposed to. The written plan is in here. You have a summary statement of the written plan's contents that I handed you at an IDG. And that sheet was titled Quality Assessment Performance Improvement Team. And it's an outline. And that form explains to you that everybody's on the team. Who's everybody, Alicia?
Every single person that we work with, our DME company, our pharmacy, every single person that we come into contact with that helps our hospice organization is on the Qapi team.
Absolutely. Good answer. Good answer. So this question says, well, how do you use the data elements? Well, first of all, what's a data element? Okay? So what they want you to know is that whether you call them data elements or indicators is another word, they want to know what it is you're looking at that you think you need to do better. And how do you know you need to do it better, or what makes you think you need to do it better? Okay? So from a common sense standpoint, if every Wednesday when we went to IDG, we heard the same complaints say, it wouldn't take very many Wednesdays till we knew what we could do a better job with, right?
Right.
So from a common sense standpoint, we have a feel in general when we think there's something we could improve on, right? Mm-hmm. Okay. So if we felt that way, what would we do what would we do if we wanted that to be one of our indicators or one of our data elements? What would we do if we just sort of had this idea that maybe we could do a better job with that?
Well,
just
first you want to look at all of the data, or what all of the complaints are about, who's involved in them, and keep asking yourself, well, why is this happening? Why do they keep complaining about this? Is there anything that we can do better to improve something? And just keep asking why and why and why until you figure out what we can improve on, and then go from there, I guess. That's
a great answer. It's a great answer. And that why is the basis of what we call root cause analysis. When we identify a problem, we use root cause analysis and keep asking why. And to really confirm if we have a problem or not, we're going to measure the data. So one of the things that all the staff is involved in are chart audits. And in the chart audits, they go through and they look for a particular type of piece of information. And probably everybody watching this has been involved in a chart audit, where our particular one, the clinical record review, is like 3 pages long, and it asks you all these questions, and you look in the medical record. Well, we take that information and we compile that into a document that shows us if we really have a problem with that or not. Are we getting the comprehensive assessment done in the length of time we're supposed to? Does the social worker get out there in 5 days? Does the chaplain get out there in 5 days? We measure that. If we don't have a problem with it, if our measurement is good, then it doesn't have to be a data element. We don't even need to take the time to measure it if we don't think we have a problem with it. So the way we identify what we want to measure is when we think we have a problem. If we're not sure if we do or not, we actually get figures and data. If it's a problem, then we implement a plan, we measure it, and see if we can solve the root cause. Okay? So some of the indicators, some of the possible things are pain control within 48 hours of admitting somebody, or managing what pain levels were in the patient's last few days. Did we start a bowel program, something for their bowels, the same time we started an opioid, because we know that narcotics slow the bowel and that they cause constipation. The indicators that Medicare and the conditions of participation and CHAP expect you to work with and pick are high volume, problem prone, high incidence of error, okay? And so all of these apply, don't they?
Mm-hmm.
To almost every single patient. It's a rare patient that, you know, so we can, but if we don't have a problem with any of them, and we know we don't have a problem with any of them, we don't have to measure them. There are some we do have to measure. That's why on this particular chart, it's down here. We do have to measure things like family satisfaction. We have to send surveys out. We have a third-party vendor that does that for us. As a Qapi nurse, you're going to love this. The company that does our satisfaction surveys, they aggregate the data for us, and they do what's called a benchmark, and they show our satisfaction survey results in comparison to the national figures and the state figures, so that we can see how we're doing. And then they have a couple of formats where you can see even the leaders in the country for Medicare certified hospices and where you stand next to the leaders. And so, yeah, and
really cool.
Yeah, and I see why you're smiling like that. I'm proud of that page too. That's
really
pretty nice,
awesome.
isn't it? Yeah. We're looking at a page where the leaders are in the 80s and we got straight hundreds. So, and even this, I'm even proud of this. Usually when you send out satisfaction surveys, you're lucky to get them back. You know, anything around 15 to 20% in home health or hospice is considered pretty good. So they can even send us the rate of return. Nationally, the rate of return on this particular survey is 26.99, and ours is 28.6. So we even beat that. People return surveys when they're really pleased with your work. So anyway, so this is aggregated data from family satisfaction surveys. So this question, how do you use the data? Well, if the data indicated that our after hours or weekend on call, because that's a particular question, if that indicated that that our patients and their families were only about 25 to 30% happy with that, that'd be an area we could improve on, right?
Like how we implemented the LVN.
Tell me about that.
So I know that we were getting really busy with on-call. On the weekends we only had one registered nurse who was always on call. And so possibly we looked at that data and determined that families weren't happy with our results. And so we implemented having an LVN on call during the weekends, as you all know now, so that we can get out to our patients quicker, and that if we have an RN who's stuck in a start of care for 3 hours, that at least our patients can still be seen by the LVN, making them happier.
That's a perfect example. That's Qapi in action right there. Took too long to get the nurse out there because she was tied up somewhere else. Put another nurse on, beat all the statistics. That's Qapi. That's a perfect example. So I'll let you see these when we're not taping because it'll make you really happy. Alrighty, so that's one example. Do you guys remember the example we just talked about at an IDG not long ago where we had a lot of falls? And we knew we were having quite a bit, and so we tracked the falls and we measured how many from month to month. And then we did training for ways to reduce falls and teach the family and the patients. And then it just announced at a recent IDG meeting that we're going to try yet another thing. Even though what we're doing is working, every month's going down, what are we going to do?
We're going to provide our patients with bells.
So they can ring their bells. You can ring your bell. Sorry. So they can ring their bell and a caregiver will come. Sorry, you guys, it's been a long year. Anyway, so yeah, you might want to cut that part out, Luke. Okay, so that is a perfect example, two good examples of how we, IHM members, integrate the data elements into our performance appraisal program and describe how we use that aggregated data to improve a problem.
Yep.
All right, that makes sense to you?
Makes sense.
Okay, good. Welcome back. This is part 2 of our Qapi training with our new Qapi nurse. And in addition to the quality indicators that we measure, tracking, the audits, etc., there are big chunks of information we're required to keep and report annually. Our budget and how we met it, the length of stay our patients are on, all of that stuff on an annual report is considered part of Qapi, because when you figure out your length of stay for a year, if your lengths of stay are too long, meaning way longer than the national averages or the state averages, then you want to look at why. Maybe you're signing your patients on too soon. And so some of the data we're required to look at only on an annual basis. And you've heard me talk about the OSHPOD report that I just got through doing in March. That has all that by diagnosis. And, are we doing more visits to private pay patients than we are to Medicare patients? Or what about our charity care patients? Are we treating them differently than we're treating Medicare funded patients? You know, so we have to prove all of that, which is why I so consistently apply the rules when somebody says, well, should we pay for this med?
Yes.
Because we can love our patients and we can even enjoy being at one house more than another house. That said, we can't provide something for the house we'd rather be at unless we're going to provide it for the house we wish we didn't have to go to. So we're required to prove there's an equitable treatment of patients. So, and so that goes in annual reporting stuff. A couple months ago, I asked everybody to do what was called a SWOT analysis, which you participated in, which is where annually we identify what our strengths, weaknesses, opportunities, and threats are, so that it can kind of guide us into maybe some decision making for what our opportunities are. All right, let's put a plan of action in place to cash in on those opportunities. What the threats are, how do we reduce those, okay? That's a part of Qapi. As well as, for all of you, our TB exposure control plan, the hazard communication training, the annual OSHA, that's all part of the Qapi plan, okay? On your interview guide, the only remaining Qapi is the very last page for you, which is page 24, which is Hospice 3.3b. Staff can describe how collected data is utilized at a functional level. So if you're watching this one before you watched Qapi Part 1, I'll tell you that at the end of Qapi Part 1, Alicia gave the perfect example. When this question comments at a functional level, the surveyor, are hoping that the staff, all of you, in any discipline, in the office, any discipline in the field, can give an example of something that you're doing, something that affects you, that's a direct result of Qapi. That was either a performance improvement project, a PIP, or that was something, a part of the bigger picture that affects them now. So if the surveyor asks one of our nurses that question, they might talk about a form, that we changed the form because we didn't need that information or it took too long that way, or whatever.
Like the fall report form. It used to be a lot longer, and it was taking a lot longer for all of the nurses to fill it out, which was, taking longer for our paperwork in general to even get turned in, which is the 48 hours. So the form was shortened a lot, and it makes it a lot simpler now for nurses.
I love that. See, I totally forgot that. And that was a long time ago. That was over a year ago.
Yeah.
But you're true. But
Yeah.
That's true. That came out of a performance improvement project for how can we streamline the paperwork? How can we save you time? So that's a definite nursing one. If you were a chaplain, and if one of the chaplains is asked, well, how do we use that data? then I would suspect that you would think quickly about the bereavement survey feedback. When family members say that they got just the right amount of calls, for instance, because that's one of the questions, that you know the plan we have in place seems to be working. If your feedback was, well, I wish they would have sent me more stuff, then we know to send more, and so we're sending the right amount now. So every discipline, I hope, can give examples. You sit in IDG and hear the changes happening all the time. You get those printouts that have the bar graphs on them and the data, and you're rolling it. So that's it on your interview guide, but don't go away, because I still have to teach Alicia a few things, and that is that we report stuff quarterly, okay? And so if we go back to that calendar that we were looking at, that's, by the way, tabbed under the word calendar. So when we look at this calendar, this is a tool to help you see how often we should be doing something. So when we do patient-client satisfaction, how often?
Monthly.
Yeah, it's an ongoing basis. Those surveys go out, data sends them out on a monthly basis. And Audrey right now is compiling the names and addresses and who data is sending it to. For instance, on the patient-client complaints, all right, how often are we doing the complaints for our satisfaction, for our Qapi?
When they come in, we fill out the complaints and the complaint form, right when the complaint comes in.
That's right. We fill the form out when it comes in. And then as soon as I get the finished product, I log it into the thing. On a monthly basis, we look at how many we had, because if we seem to be on a rise, we kind of need to look and talk about why that's happening. So, and what about those clinical record reviews that you taught the staff to do and worked so hard? That you taught the staff to do before I even taught you how to do, by the way. So,
yes,
for those,
please.
Those of you probably didn't know that, because the way Alicia works, you'd never know that. But I've never even completely gone through this with her, so you did a really terrific job for not having that. So,
well, these get done quarterly as well. So we just finished the first quarter, which was handed in the end of March.
We summarize. We summarize the results of the quarter. Yeah. But how often can you do these?
On an ongoing basis.
Yeah, I could make you sit in here every day and do these every day all year long, but I won't. And so, and then at the end of the quarter, we aggregate the data, right? Okay. So what else is in this quality assessment performance improvement plan? Well, annually, I have to prepare an annual agency evaluation. I have to prepare it in March, you see on the calendar, and I present it to who?
To the governing body.
Here's a test question for you. Do you know who the governing body is?
I do. It's Wendy and Donna.
You do. You make me so proud.
Well, you're a teacher.
I actually thought I was going to stump you on that one.
Really?
Sort of.
Oh.
Yeah, that was cool, Alicia. You were
I surprise you.
Okay, so how often do I have to report those results?
You have to report it annually, but...
And what month do I report it?
In May.
Yep. See, so here, just like, what's another part of the Quality Assessment Performance Improvement Program that everybody watching hears on a regular basis?
Are there any adverse events?
Because that's what we say every Wednesday, the adverse events. Now, just as a thought for you, because I could see a surveyor doing this, she will probably ask you, or you, if you think a fall is an adverse event. And the answer is yeah. So I'm answering for you because we don't come to IDG and say we had 3 falls today. Or instead, we aggregate your data and present it to you. But technically, an adverse event is something you didn't expect to have happen and wished it wouldn't have. I mean, okay. Occurrence adverse events they're not predictable. You wish they wouldn't have happened. Now, most of the time when a surveyor is talking about occurrences, they're looking at something drastic. Was there a med error? Did a patient die? Those sorts of things. We don't have those kinds of occurrences. A sentinel event is the way you define when somebody dies. Okay? So our adverse events are patient complains of medication delivery maybe, and they missed a drug. The most adverse events we have are patient falls. All right? And we track those as they happen, don't we?
Right.
Okay? And aggregate the data monthly, right? Okay? So, and the governing body is presented with all of the results of the year, okay? So tell me about our infection control program, which is a part of the Qapi, right? Because you're the infection control nurse too, aren't you?
Yep.
Which is a part of the Qapi. So tell me about that. Tell me about infection control.
Infection control, we track all of the infections that all of our patients have. If they come to us at admission with an infection, that obviously was not our infection. So if they were at the hospital or what have you, and they were started on an antibiotic and they had that infection already, that's not one that we would track because that's one that they had already acquired. If a patient was admitted from the hospital and comes home and anywhere between the first time that they signed on and within 72 hours, if they get an infection in that time, that still would not be our infection. That's the infection from the hospital or the nursing home or what have you. Any infection for any of our patients that are on service greater than 72 hours or more, those are the infections that we track and we report, which I'm doing on an ongoing basis, and I always, anytime the nurses leave on the line or an IDG and they let us know about an infection, then I'm tracking that on a log and filling out a form for that as well to make sure that the antibiotics are effective, or if we had to have another dose of antibiotic or what have you.
That's right. That's a good answer. That's a perfect answer. Because a bug can be in the incubation period for 72 hours. So they could already have the bug but not have a sign of an infection until their third day. So we're only responsible at the 72 hours after they're admitted. Then it's considered ours. So I got a question for you and make you think for a minute. I think that's great. I think that if I were a surveyor, I think that sounds great. You ask the nurses to report that, and you listen on that line you told me about to hear. But what if they don't put it on the line?
If they don't put it on the line, I also am reading every single doctor's order that comes in. So I read them before they're signed, and I also read them after they're signed by the doctor. So I will pull all of those orders, usually after they're signed, and make sure that I have it tracked on the log that infection is tracked.
What if the nurse is so overwhelmed that she doesn't leave it on the line, and she's so behind in her paperwork that she almost doesn't work for me anymore? She's so behind in her paperwork that she hasn't turned her orders in yet. Then how would you know if we had an infection?
Well, during IDG, we always ask those wonderful questions. Are there any infections that we that have not been reported or that we don't know about? And that's how. And then whenever that comes in, I also make a little note of that as well.
There is absolutely no reason for me to be sitting here doing this with you.
Well, thank you. I'm glad you are.
But that said, let's look at the Qapi section itself.
All right.
And see what's in there. Have you had a chance to look at your Qapi section?
I have.
Because anything you say will be used. No, it will be helpful to the staff. So let's find our Qapi section. Now, those of you watching the video, you don't have a Qapi handout section unless you are one of the program management people. I did not give the Qapi section to all of the field staff. You have your sections and your Qapi questions. But Alicia, as the Qapi manager, has her own section, which is on page 17 for the managers that are watching this, and it starts near the bottom. Let's just see if let's just see what's on here, all right? So the first one, 6B, Qapi manager describes the rationale for the performance improvement process and the definition of specific service outcomes. You've already done that, sitting here. The rationale for the performance, and I'm sorry, am I looking at the two identicals, I believe?
Pretty
Yeah, so outcomes are targeted, and we benchmark, and that, oh, there's something for you, benchmarking against other, who do we use or what do we benchmark against? And so, just to help you understand that, when the surveyor says, well, who do you use for benchmarking?
Data.
Data's one answer. Can you think of another one? Think about all those things I hand out to all the staff all the time that show, you know, how the community standard is for an RN to do 4 visits a day or an aide to do 5 to 6 visits a day in an 8-hour day.
I get those all the time, and I don't know.
So there are industry-specific journals, and so the American Hospice Association puts stuff like that out. NHPCO, the National Hospice and Palliative Care Organization. So we're benchmarked against them. Last summer we participated in a pilot project with CHAPCA, the California Hospice and Palliative Care Organization, remember? And we got benchmarked against 18 organizations in the county.
Right.
Yeah, so she's going to want to know that you understand that what are we comparing ourselves to? Okay? So it wouldn't make much sense for us to compare our figures to the figures for someone who lives in rural Missouri, where from patient to patient may be 105 miles, literally, right?
Right.
You got to be benchmarked against similar. Okay, so that's what that is. All right. And then your next one is the rationale, evaluates progress, continually evaluates progress toward outcomes, identifies new areas to improve, or repeats what you need to. Okay, so we already talked about that, right?
Yeah.
And you've already given me examples of how we use the data at a functional level. Okay, and planning, evaluating activities. I mean, okay, so. There isn't anything on here she's going to ask you, Alicia, that you don't have a complete, solid understanding of and can answer her successfully.
Okay.
Okay?
Good.
So, I'm pleased with, and that makes me feel really good about what she's able to share with you guys, because I know now that she's giving you all the right stuff, not that I ever doubted you weren't. So, all right? So, I hope that this presentation actually contributes toward your own personal quality assessment and performance improvement. Thank you. See you next time.